Hello, everyone. Thank you for joining us. Today, we are joined by Betsy Moeller with CorMedix, and she will be presenting over renal disease topics, things to look for in patients that you might have come through your clinics or through your ED setting. If you're watching this recording and if you have any questions at all, please do not hesitate to reach out. With that said, Betsy, I will turn it over to you.
Thank you, Laura. And good morning. Again, this is Betsy Graham-Moeller, Senior Medical Science Liaison for CorMedix. I'm also a native Oklahoman, so very happy to be here this morning. As Laura mentioned, the goal today is just to provide a general overview of renal disease, how renal disease progresses, and then consequences associated with renal disease, and also giving a little bit of background around hemodialysis with the intention of promoting improved health outcomes, including patients in rural areas. So let's just dive right in. So renal disease, as we know, is a global health issue. It impacts about 850 million people. But in the U.S., there are about 37 million people with chronic kidney disease, which is typically characterized as a progressive decline in kidney function. Chronic kidney disease is most common in patients or individuals 65 years of age and older, but it does occur in younger age groups. But certain individuals, like individuals with diabetes and hypertension, are at increased risk for developing chronic kidney disease. So actually 1 in 3 individuals with diabetes and 1 in 5 individuals with hypertension have chronic kidney disease. End-stage renal disease, or ESRD, is the last or final stage of renal disease or dysfunction. So about more than 800,000 individuals in the U.S. live with end-stage renal disease, but men and individuals from African, Hispanic, and Native American origin are at increased risk compared to their Caucasian counterparts. About 550,000 patients with end-stage renal disease are on dialysis, and about 250,000 individuals require renal transplant. And since our audience is largely rural today, I also want to highlight that there is a high incidence of diabetes, chronic kidney disease, and end-stage renal disease among rural residents. And according to the U.S. Renal Data System, in 2017, nearly 240,000 Americans who live in rural areas have end-stage renal disease. Rural residents has been associated with higher mortality rates, worse health outcomes compared to urban counterparts. Rural residents often have less access to specialty care and higher mortality rates while on dialysis, and are also less likely to receive a renal transplant. As I mentioned, chronic kidney disease is a condition that progresses over time. But what's alarming is that early on in the course of disease, patients are often asymptomatic. So they often do not know that they have chronic kidney disease until they reach advanced states. So this really highlights the need for screening, early recognition to promote optimal outcomes and to initiate treatment and management. Chronic kidney disease is evaluated by obtaining estimated glomerular filtration rates. This represents kidney function, and also evaluating for the presence of albuminuria or proteinuria. Almost all patients who have end-stage renal disease will start dialysis or have a kidney transplant. Chronic kidney disease is categorized as stages, and it is staged 1 through 5 based on an individual's eGFR and kidney function. So stage 1 means that a patient has possible kidney damage, but with normal kidney function. So their eGFR would be about 90 or above. Stage 2 indicates mild loss of kidney function with an eGFR of 60 to 89. Stage 3A represents mild to moderate loss of kidney function with an eGFR of 45 to 59. Stage B reflects moderate to severe loss of kidney function with an eGFR of 30 to 44. Stage 4 depicts severe kidney loss of function with an eGFR of 15 to 29. And then, as I mentioned, stage 5 is considered kidney failure or end-stage renal disease with an EGFR of less than 15. So risk factors are characteristics that increase the likelihood of an individual developing a condition or disease. So, for example, diabetes and hypertension are the two largest drivers for developing chronic kidney disease, but through early recognition, screening, early recognition, and management and treatment, the course of disease can be slowed by treatment and management, appropriate treatment and management. Heart failure is also a risk factor that can be managed to slow the progression. Obesity is a risk factor that often can be prevented or managed appropriately. And then any individual or patient with a family history, we want to implement screening and early recognition to slow the progression of disease through appropriate management and treatment. And then individuals who smoke are also at increased risk, so we want to implement smoking cessation measures. And then causes of kidney disease. So diabetic kidney disease is the leading cause of end-stage kidney disease in developed countries, and that includes the U.S. as well. It's considered a microvascular complication. It occurs in type 1 and type 2 diabetes. This disorder represents persistent albuminuria and a progressive decline in glomerular filtration rates, largely due to marked inflammation, which causes vascular permeability, and this eventually can result in albuminuria, intraglomerular hypertension, which results in proteinuria, leading to chronic tubular injury. And then contrition can lead to atherosclerosis, which can lead to kidneys not receiving the adequate oxygen and nutrients required to filter the blood. Environmental exposures can cause kidney damage. So smoking, pesticides, heavy metals. So again, we want to implement smoking cessation measures and then try to limit our exposure to pesticides or heavy metals. If we work around these environmental agents, we want to minimize our exposure, wear appropriate equipment and protective gear. Infections can also cause kidney damage. So, for example, viral infections like human immunodeficiency virus and hepatitis, or bacterial infections like staphylococcus or streptococcus. Inherited disease can cause kidney damage. So, for example, autosomal dominant polycystic kidney disease is the most common type of inherited kidney disease. This is characterized by numerous cysts in the kidneys, and it's the fourth leading cause of renal failure. Of course, injury, for example, acute kidney injury, this is characterized by a rapid decline in glomerular filtration rates, and it can result in accumulation of metabolic waste. So this slide just really provides an overview and the importance of early screening, early diagnosis to prevent progression of disease, and incorporating ongoing renal function monitoring in patients who are high risk or who have concomitant diseases. And then also when patients reach the point where they need nephrology care, we want to promote early referral to nephrology. We also want to promote adequate communication and collaboration between primary care practitioners and nephrologists. So once a patient progresses to the point that they need dialysis, there are two types of dialysis, hemodialysis, which is the most common, and peritoneal dialysis. Peritoneal dialysis involves infusing a dialysis solution into the peritoneum. The solution remains in the peritoneum where the solution absorbs excess waste, and then it is removed from the body. But most patients undergo hemodialysis, which will be our focus for today. So during hemodialysis, a machine removes the blood, filters it through an artificial kidney called a dialyzer. Waste products and excess fluids pass through these mesh tubes into dialysate, which is a fluid that consists of water, salt, and electrolytes. The filtered blood is then returned to circulation. And this is done about 3 times a week for approximately 4 hours during each dialysis session. So to obtain venous access to undergo hemodialysis, patients have several options. One is an arteriovenous fistula, which involves anastomosis of an artery and a vein, or an arteriovenous graft, which also involves anastomosis of an artery and a vein, utilizing a synthetic conduit or tube, or a central venous catheter, otherwise called CVC. This involves placing a catheter into a large central vein. So each type of venous access device has associated complications, but AV fistulas have the fewest complications and risks associated. However, once placed, they take about 2 to 4 months to mature before they can be accessed and utilized for hemodialysis. Arteriovenous grafts can be utilized after about 2 weeks of maturation. They do have more complications and risks associated compared to AV fistulas. And then we have central venous catheters, otherwise called CVCs. They can be used immediately, but they're meant for more temporary access, but they have the highest complications and risks associated compared to AV fistulas and AV grafts. So there are 2 types of CVCs. Non-tunneled are percutaneously inserted into central veins. They're meant for short-term use, so typically less than 3 weeks. They're more commonly used in emergent situations. And then tunnel catheters are percutaneously inserted into central veins via subcutaneous tunnels. They're meant for longer-term use, so they can be used for weeks to months. They do have lower rates of bloodstream infections compared to non-tunneled CVCs. So an example of this would be a Hickman catheter. So there are several types of complications that can occur in this CVC hemodialysis population. Catheter-related thromboembolic events could include clotting within the catheter lumen, deep vein thrombosis, pulmonary embolism, or mechanical complications can occur, which can include misplacement or breakage, puncture, hematoma, or catheter-related bloodstream infections, which are caused by intraluminal or extraluminal bacteria. We're going to take a little bit of a deeper dive into that in just a few minutes. But the catheter-related bloodstream infections are the most common complication for CVCs in this hemodialysis population. So let's dive into how this occurs. So there are numerous organisms that cause bloodstream infections in this patient population. However, Staphylococcus aureus is the most common pathogen or organism that causes the bloodstream infections in this patient population, followed by Staph epidermidis. There are antimicrobial resistant cases, with methicillin-resistant Staphylococcus aureus representing almost 40% of resistant cases, followed by cephalosporin-resistant E. coli. So what we're looking at here is an inserted CVC for hemodialysis. And so there are 2 main routes that organisms can enter the bloodstream to cause a bloodstream infection, which are the extraluminal pathway and the intraluminal pathway. And the organisms can gain access to the device through invasion at the skin insertion site, contamination of the catheter hub, hematogenous spread from a distant site of infection. So one thing that comes to mind would be, for example, a pneumonia, or infusion of contaminated fluid through the device. So once the device is in place, microorganisms can adhere to the extra or intraluminal device surface. Pathogens can then incorporate into what's called a biofilm, which is basically a structured community of microorganisms, and they produce this self-produced matrix called a biofilm that adheres to the surfaces of catheters, dialysis lines, or other types of medical devices. And this adhesive matrix provides kind of a safe harbor or a secure environment for bacteria or organisms to grow and replicate more effectively, which they can then disseminate through the bloodstream. Also, thrombin and platelets can attach to the catheter. The platelets can aggregate and fibrin sheaths can form, resulting in thrombosis. So also within this biofilm, over time, mutations and genes promoting antibiotic resistance can accumulate. Because the bacteria are in close proximity, they can share these mutations and resistance genes. So further enhancing the survival against treatments. The formation of the biofilms makes infections more difficult to treat, and bacteria within the biofilm can become less susceptible to antibiotics. So this can lead to persistent infections and increased difficulties in treatment. Also keep in mind that biofilm can form within 24 hours of placement of a line or device. So we have modifiable and non-modifiable risk factors for developing a bloodstream infection. So for example, having multiple CBCs, because remember, each line is a potential source of infection. Of course, parenteral nutrition, heavy microbial colonization at the insertion site, or failure to follow maximal sterile barrier precautions. Also, long duration of dwell time. And then unmodifiable risk factors. So factors that we can't control are things like age, gender, comorbidity, ethnic background, and race. And then patient-related risk factors would be longer durations in the hospital, high Apache scores, multi-lumen catheters, or being immunocompromised. So this slide represents information from a meta-analysis, and it compared patients who were receiving hemodialysis via a CVC versus an AV fistula. And what they found was that patients who were undergoing hemodialysis with a CVC had 53% higher risk of all-cause mortality, more than 2 times higher risk of fatal infections, more than 4.5 times higher risk of non-fatal infections, and 68% higher risk for hospitalization compared to those with an AV fistula. So there are some disparities also among this, what we call HD CVC population of patients. This information here is from the U.S. Renal data system. And what the USRDS has mentioned is that about 90% of the youngest adults initiate hemodialysis with a catheter. And this is despite programs like the Fistula First program, which was initiated back in 2005 to promote the safe use of AV fistulas in all patients in which it was appropriate due to the lower risks and complications. But also, previous nephrology care is inversely correlated with hemodialysis and initiation. And what that means is that patients who received nephrology care for more than a year before they initiated hemodialysis had the lowest rates of CVC usage and the highest rates of AV fistula use. And then also, being a Medicare or Medicaid recipient was associated with higher rates of catheter use. And then a 3-year cohort study performed by the U.S. Renal data system found a disproportionate increase in CVC duration by racial or ethnic group. And they found that Black patients spent 40 more days and Hispanic patients spent 30 more days with a CVC compared to their Caucasian counterparts, and that women had longer durations with a CVC compared to men. So at what point, if a patient presents to the emergency department or to your clinic that has a CVC, at what point would we suspect a bloodstream infection? So just general symptoms can include just general malaise, nausea, or high fever, rigors, hypotension, or change in their mental status from baseline. And then site-specific symptoms that would alert us to a bloodstream infection would be erythema, swelling, tenderness around the exit site, or purulent drainage from the exit site. And then if they present with fever, chills, or idiopathic hypotension, that would also give us clues to the fact that they're developing or have developed a bloodstream infection. And then, of course, we would want to obtain appropriate blood cultures for testing. So catheter-related bloodstream infection, otherwise called CRBSI, and central line-associated bloodstream infection, otherwise called CLABSI, these two terms are often used interchangeably, but they have distinct differences. CRBSI is a more clinical and patient-focused diagnostic tool, and it requires microbial evidence of the infection originating from the actual catheter. And it requires specific criteria to confirm that the source of the infection is the catheter itself. Whereas CLABSI is more of a general surveillance term used by the CDC, and it identifies infections in patients with central lines, but it doesn't necessarily confirm the central line as the definitive source. But because CRBSI requires specialized microbial testing techniques, that's not always available in most facilities or all facilities, you will probably hear the term CLABSI used more frequently. So treatment for CLABSIs or bloodstream infections in this population have not been well established. So we would want to follow implemented guidelines. So following source control, so removing a CBC if suspicion of the CLABSI is high. Of course, we would want to implement antibiotic treatment for broad coverage, so gram-positive and gram-negative organisms, or if candidemia is suspected, we would want to implement appropriate treatment for candidemia. And then we would want to obtain susceptibilities through blood cultures. And then duration of therapy would depend on whether the bloodstream infection is complicated or uncomplicated and what organism is causing the bloodstream infection. So there are times when a CBC needs to be discontinued or removed. Indications for removal or exchange would be infections caused by Staphylococcus aureus, Pseudomonas, or Candida, or if a patient has no clinical improvement within 48 to 72 hours after empiric antimicrobial treatment for gram-negative bacilli and coagulase-negative staphylococci, or metastatic or persistent fever or bacteremia for 72 hours, even though they've been given appropriate antimicrobial treatment. So this is a timeline evaluating day 1 through 12 months. And it was a meta-analysis that evaluated 470,000 patients who initiated hemodialysis with a catheter, using this catheter as a bridge while they were waiting for permanent access. But what they found, having the CBC was associated with higher mortality, higher infection, and lower patency. So really the thing to keep in mind is that a patient is at risk for developing an infection the entire time the catheter is in place. And so this slide just basically tells us that patients can be treated, they can undergo hemodialysis in the outpatient setting. They can acquire a CRBSI at the dialysis center and be treated as an outpatient, or they can develop a CRBSI in the outpatient setting, but be treated as an inpatient, or they can be hospitalized for a reason aside from a bloodstream infection, but develop a bloodstream infection while they are hospitalized. And so certain organisms have a higher rate of mortality associated, and also secondary infections can increase mortality. So for example, for endocarditis, mortality is increased by 2.5 times. Progression to endocarditis can occur when pathogens from the bloodstream adhere to damaged or native heart valves or cardiac tissue or implanted devices, so like prosthetic valves. So this results in the formation of infected vegetations leading to infective endocarditis. Staph aureus is the most common causative pathogen for bloodstream infection in this group, and it can significantly increase hospitalization rates. Many MRSA strains have been associated with all-cause mortality, persistent bacteremia, and metastatic complications in this patient population. And then something else I'd like to point out is that infection is the second clinical leading cause of death in this patient population, followed by cardiac issues. So pretty substantial for patients when this occurs. So once a patient does develop, or if they develop a bloodstream infection, they are at risk for long-term consequences. So there are increased risk for congestive heart failure, myocardial infarction, peripheral vascular disease, and stroke. So prolonged inflammation and cardiac involvement can weaken heart muscle over time, leading to heart failure. Septic emboli or just inflammation or damage can result in coronary artery occlusions or reduced blood flow, which can result in a myocardial infarction for these patients. Also, chronic infection or chronic inflammatory states can accelerate atherosclerosis, and this can increase the risk of peripheral vascular disease. Also, emboli or inflammatory damage to like cerebral arteries can cause ischemic events like stroke. So keep in mind that patients in this population are at high risk of developing endocarditis, more than tenfold risk compared to those who do not develop a bloodstream infection. So there's been a long-standing awareness from the American Psychological Association that there's a strong correlation between chronic disease and depression. So what we're looking at on this slide, it was a study conducted of about 200 patients who were undergoing chronic hemodialysis, and the goal was to evaluate their health-related quality of life. And what the researchers found was that 61% of patients reported depressive symptoms and a reduced quality of life, and that they were associated with complications like repetitive infections, pain, anemia, and weakness after their dialysis sessions. So we've touched on patient-related consequences of bloodstream infections in this hemodialysis population, but let's talk about a few economic consequences as well. So we want to keep in mind that bloodstream infections are largely preventable. So when patients do develop a bloodstream infection, not only is this an unnecessary burden on their health, but it's also an unnecessary burden on the healthcare system. Keep in mind that when patients are on the transplant list, if they develop a bloodstream infection, they could lose their place in line or be placed on hold for receiving their renal transplant. Also, patients who develop bloodstream infections incur longer hospital stays, higher rates of admission, and then also the use of broad-spectrum antibiotics are often used. The average cost in 2020 to treat a catheter-related bloodstream infection was greater than $130,000 per episode. So again, comparing patients who develop CRBSIs compared to those who do not, they have increased hospital admissions, longer lengths of stay, and higher outpatient visits. Again, the cost incurred for inpatient and total costs for patients that have a bloodstream infection versus don't are significantly higher. And what's interesting is that CRBSIs are not the most frequent. They're one of the least frequent hospital-acquired infections, but they are the most expensive to treat, and they also have the highest estimated excess deaths compared to some of the other hospital-acquired infections. So the CDC is targeting hospital-acquired infections. 1 in 25 hospitalized patients will develop a hospital-acquired infection on any given day. The excess healthcare cost of hospital-acquired infections exceed $34 billion. So what can we do? What can we do to help these patients and to prevent bloodstream infections from occurring? So just general guidelines include education and training of all healthcare staff. We want to promote hand hygiene, the use of aseptic technique, maximum sterile barrier precautions during insertion, maintenance, removal, and then antimicrobial use with or after CVC insertion. And then I'd like to point your attention to the right side of the slide here. I found this pretty interesting. This study was written about a hospital that implemented bloodstream infection prevention protocols. And after they implemented the infection prevention protocols, they had more than a 60% reduction in bloodstream infection rates. So they did a further analysis to look at the economic impact. And what they found was that for every $100,000 they spent on bloodstream infection prevention, they found that hospitals could save about $310,000. There are several organizations who provide guidelines for preventing bloodstream infections, which include the CDC, KDOQI guidelines, and SHEA. One approach that has become increasingly popular over the past several years is utilizing catheter lock solutions to prevent bloodstream infections and to prevent clot formation and microbial adhesions. Common agents include heparin, normal saline, antimicrobial agents, antibiotic or antiseptic prophylactics. So this is the last slide, and I really like this slide. To me, it just says, putting the patient first. So by preventing bloodstream infections in this patient population, we can decrease mortality. Patients can stay on the transplant list. We can see a reduction in hospital admission and lengths of stay. We can minimize exposure to antibiotics. And also we can avoid increased risks of cardiovascular morbidities and an overall reduction in healthcare. So thank you for your attention today.